Greetings to each and every one of you. I'm honored to be invited to this lecture for the Medico Academy, and I thank the organizers for this opportunity. My name is Anita Bhatia, and I am a professor of cardiac anesthesia and perioperative medicine at the University of Louisville in Kentucky, USA. The lecture today is on short-term mechanical circulatory assist devices for the failing heart. There has been an exponential increase in the mechanical circulatory devices available in the management of acute cardiogenic shock and acute decompensated heart failure. Cardiogenic shock, as we all know, is a life-threatening event. Advances in mechanical circulatory support have significantly expanded the treatment options for such patients. Each device has its own technical consideration, and the decision to use a device is dependent on several factors, which we will learn as we go along. There is evidence, however, that the hemodynamic support offered by short-term percutaneous mechanical circulatory support devices is instrumental in reducing the length of stay of these patients in the hospital and improving their 30-day post-discharge outcome. What are the objectives of this lecture today? Well, we're going to be reviewing available short-term percutaneous and non-percutaneous mechanical circulatory support devices for refractory acute heart failure or cardiogenic shock. We will review the pathophysiology and the burden of cardiogenic shock, and we will, in the second part of this lecture, understand peripheral extracorporeal membrane oxygenator, and also review the current evidence, the contraindications, the complications, and future directions of these devices. So what are these devices? Well, they include a spectrum of durable mechanical devices, and they are designed to temporarily or permanently support the function of the failing ventricles. And they improve not only the function of those ventricles, but they improve the systemic and organ perfusion by improving the stroke volume and the cardiac output. Thus, they will help restore the balance between myocardial oxygen supply and demand, because they also help to unload the ventricles which are failing and increase the stress work index. Well, what are the pre-lecture questions? So before we proceed too far, let's look at some pre-lecture questions so that we keep that in mind as we go through this information on this lecture. So regarding the circulatory assist devices, which of the following statement is true? A, short-term mechanical circulatory devices need an oxygenator. Stroke is an unlikely complication of temporary devices. Limb ischemia is a known complication of these mechanical assist devices, or is it all the above? Well, you don't have to answer just now, but we will continue with our lecture. So what do these devices do? Well, as I said, they perform the function of the heart and they work as a pump. So if it's a left-sided device, meaning that it's supporting the left ventricle, then it is actually helping evacuate the blood from a non-contractile or a poorly contractile left ventricle and ejecting it into the femoral artery or the aorta itself directly. The right-sided pump will support the right ventricle and bypass it and either take the blood to the pulmonary artery, or it will take it through an oxygenator into the femoral artery. Pump types may be pneumatic, axial, or centrifugal, and they may provide pulsatile or non-pulsatile continuous flow. So what are the indications for mechanical circulatory devices? Well, we all know that refractory cardiogenic shock, which is not responsive to any medical treatment, is one of the most important indications. This cardiogenic shock could be from acute myocardial infarction or from myopathy like a stress-induced sudden myopathy like Takotsubo syndrome. Or they could be used to support high-risk percutaneous coronary intervention in the setting of a patient with cardiomyopathy who is unable to eject and maintain hemodynamics and unable to eject a good stroke volume. They may be used in acute myocardial infarction, which is complicated by acute mitral regurgitation, or a ventricular septal rupture, that the patient just goes into severe pulmonary edema and cardiogenic shock. They may be used in refractory ventricular arrhythmias during electrophysiological procedures, like ablations for atrial fibrillation or ventricular multiple ventricular ectopies in patients who will require ventricular ablations. They may be used in bridging refractory heart failure to a implantation of the left ventricular assist device. This is called a bridge to a bridge because obviously an LVAD is a bridge to a transplant. They may be used in post-cardiotomy shock following open heart surgery when it is hard for the patients to be weaned off cardiopulmonary bypass machines. Or they may be used in extracorporeal cardiopulmonary resuscitation. Sometimes there is a primary cardiac allograft failure following heart transplants. That's when you would use these devices. And mostly they are temporary. Or again, in right ventricular support in severe RV dysfunction following cardiac transplant. And you know that that's a very frustrating problem to have. So what is refractory cardiogenic shock? Well, as the name suggests, it is refractory to optimal medical management. And it's a state of critical systemic hypoperfusion due to primary cardiac dysfunction, often resulting in multi-organ failure and a very high mortality. The shock trial is what started this definition. And there are a couple other parameters that we could use, but the shock trial was, should we emergently revascularize occluded coronaries for cardiogenic shock? The hemodynamic parameters that characterize cardiogenic shock would be persistent hypotension, where your systolic blood pressure is well below 80 or 90 for over an hour or so on inotropes and vasopressors. Or the cardiac index is well below 1.8 liters per minute per meter square, with or without support. Or the left ventricular end diastolic pressure, or your PCWP, which is pulmonary capillary wedge pressure, is well over 18 millimeters of mercury. What are the laboratory parameters that would indicate that your patient is in refractory cardiogenic shock? The anion metabolic acidosis from the low cardiac output and the low hypoperfusion. What about the lactate levels? Lactate levels elevated over 2 millimoles per liter are indicative of refractory cardiogenic shock. And the patient would also demonstrate clinical signs of organ dysfunction, which include altered mental status, cold, clammy skin, and tachypnea. So in the pathophysiology of cardiogenic shock, there are two pathways that these patients can take. Either the failing pump, which causes decrease in stroke volume, will cause the multi-organ hypoperfusion, leading to acidosis, we talked about, and myocardial depression. Myocardial depression further results in failing the pump even more. Or the decreased stroke volume could cause an LV distension. LV distension means that your left atrium cannot enter blood or push blood, eject blood into the left ventricle, which is already quite distended. And therefore, there's backflow into the lungs, and your patient presents with pulmonary edema. Not just that, the LV distension itself can cause increased wall tension and increased stroke work, causing further coronary ischemia and pump failure. So the benefits of these short-term mechanical circulatory devices is to stabilize the hemodynamics in these patients and to improve their stroke volume. So by helping the left ventricle pump or the right ventricle pump, they improve the stroke volume and they improve end organ perfusion. Thus, they reduce the intracardiac filling pressures and they unload the left ventricle volume, which is very, very important. As you know, that's a precipitating cause of coronary ischemia. They reduce ventricular wall stress and myocardial oxygen consumption, and they augment coronary perfusion by making all these changes. So like we said, it balances the demand to the consumption. Or should I say demand to the supply. Now, the mechanical support serves as a bridge. Now, this bridge, when you place these devices, this bridge could be immediate survival from a life-threatening event following myocardial infarction, which pushes the patient into cardiogenic shock, or life-threatening event from refractory ventricular arrhythmias, which are seen in patients while they're undergoing their coronary intervention, or massive life-threatening pulmonary embolism that can be bridged for thrombectomy until they undergo the thrombectomy and get stabilized. Sometimes they can be used as a bridge to recovery. So patients with acute severe heart failure may have a reversible etiology. For example, Takasubo syndrome, that is, or postpartum cardiomyopathy, which may or may not require a long-term support. Then these devices can also be served as a bridge to transplant, or as a bridge for LVAD to transplant. LVAD is your left ventricular assist device. Sometimes they are a bridge to decision while you decide what can you do for this patient. Does this patient need a left ventricular assist device? Does this patient need a little time to recover? Or is this patient a candidate for transplant? And as we talk about pump devices, we have to recognize Dr. Michael DeBakey's contribution for the discovery of the roller pump, which actually went on to be used in the cardiopulmonary bypass machine. And that is what is the precipitating factor that helped develop these support devices. It is the philosophy of that, basically. And however, we have there has been an evolution from the roller pump that he used because of the excessive hemolysis that it caused. These are the little rollers that you see, and they help to push against these little tubes which carry the blood. And over time, there is a fair amount of occlusion and hemolysis. So we've now gone on to centrifugal pumps, which are impeller pumps. And here they have vanes inside. This impeller has got these vanes. And these vanes actually transfer kinetic energy into pressure energy, such that blood that is pulled into this little vortex is passed and flushed through this and leaves the base from the impeller. Therefore, it's like a positive pressure allowing the flow of the blood through these impellers. And these impellers are miniaturized, and they can be used in your LVADs as well as in the pumps for your ECMO or your tandem heart. So what are some of these short-term acute mechanical devices? Well, they can be pulsatile or they can be continuous flow type. Pulsatile are the ones that can be used like the intra-aortic balloon pump, which was, as you know, started in 1960 actually. And then you have the continuous flow pumps, which are divided into axial flow and centrifugal flow. We already talked about the centrifugal flow, but in addition, we've also got these small impellers or small percutaneous heart pumps, which can be placed transcutaneously or through the femoral artery and the aorta into the heart, and they can help offload the ventricle. You can also classify the current mechanical assist devices into devices that support the right ventricle or ones that support the left ventricle. So the ones that support the right ventricle are the impeller RP, the tandem heart, which is the RA to PA, and the ECMO, which is the veno-arterial ECMO. The left ventricular support devices are again the ECMO, the intra-aortic balloon pump, the impeller, which is found in about 3 types, depending upon the liters of cardiac output that it's able to generate, and then the tandem heart. And as we see over a period of time from 2004 till almost recently, there has been an exponential increase in all these circulatory devices. These are our permanent ones. These are temporary ones, and all of them have exploded and helped assist these patients of acute heart failure. As we know that acute heart failure is a global pandemic. The intra-aortic balloon pump is the first one. Let's talk about that. That was introduced in 1960. And basically, it's a double lumen balloon catheter, which is again introduced percutaneously, retrograde fashion through the femoral artery into the aorta. You have to be very careful in patients with dissected aorta that is going all the way down the descending aorta, because you do not want these to be inserted into the false lumen. They use the counterpulsation mechanism, which is inflation and deflation of the helium-filled balloon at precise points in the cardiac cycle. And therefore, they not only need an EKG to guide the cardiac cycle, but they need a pulsatile right ventricle. A failing right ventricle is not going to pump blood to the left side. So there is no point using a left ventricular assist device unless the right ventricle is functioning as well. Now, the intra-aortic balloon pumps, they inflate at end systole and they result in diastolic augmentation, which is why your diastolic blood pressure improves. And the diastolic flow to the coronaries improves because, as you know, the coronaries do fill in diastole. Now, the deflation of the balloon of these, the helium-filled balloon in the pre-systolic phase causes deflation, which lowers the impedance to systolic ejection and reduces the myocardial work or the oxygen demand. So they are very useful in augmenting diastolic blood flow to the coronaries, as well as reducing the afterload and improving the systolic ejection. The intra-aortic balloon pump shock trial 2 was published in the New England Journal of Medicine in October 2012, and that surprised everybody. It was a randomized prospective open-label multicentral trial where they tried to see the advantages of intra-aortic balloon pump in patients who were in cardiogenic shock and in whom they placed the intra-aortic balloon pumps, 301 such patients, and the control group where they did not place the intra-aortic balloon pump. And the primary efficacy endpoint they were looking at was 30-day all-cause mortality. What did they find? To their surprise, they found that there was no difference in all-cause mortality, 30-day mortality, between the control group and the group that received the intra-aortic balloon pump. And some of the reasons for this were that perhaps the cardiogenic shock was too far advanced by the time they went into the intra-aortic balloon pump trial, or that the pump was inserted way too late in the course of the patient's disease. So other than the intra-aortic balloon pump, we also have the Impella that I should tell you about. The Impella is made by Abiomed, and it's an intravascularly inserted miniature intracorporeal pump, which is designed to go in through the femoral artery and go it's like a transvascular device. It will either be pushed in through the femoral artery, or sometimes, if it is of a larger caliber, called the Impella 5.0, you may need a graft in the axillary artery, and that has to be a cut down. It can provide flows from 2.5 liters to 5 liters. It's placed percutaneously in a retrograde manner, and it provides non-pulsatile flow using an axial pump. And so this is the axial pump inside here. And this pump has been inserted through the femoral artery, the aorta, the aortic valve right here, and then into the left ventricle itself. Now, there is an inlet right here, which suctions the blood because of the little pump here, the axial pump, and it ejects it into the aorta past or above the aortic valve. So you have to have a competent aortic valve here, and you cannot have a mechanical aortic valve or severe aortic stenosis, which would prevent this from being placed. The Impella also helps to unload the left ventricle, reducing the myocardial oxygen consumption, which, as you realize, is a very important function of the Impella. The percutaneous nature of the Impella has increased its popularity and utilization. So There was a comparison between the Impella 2.5 and the Impella CP, which is a better Impella and a better generation one. Of course, we've now come across Impella 5.0 as well. But the PROTECT trial compared the major adverse cardiac and cerebrovascular events at 90 days in patients who received these following acute myocardial infarction. And they found that there was a substantial decrease in the MACE events. The Impella is seen by fluoroscopy and confirmed by fluoroscopy insertion, as well as by transesophageal echocardiography, where this is a long axis view under TEE with the left atrium, left ventricle, mitral valve, and the aortic valve in the left ventricular outflow tract. And here, through the aorta, this is the aortic valve, and beyond here is the aortic root, and the device is inserted through the aortic valve into the left ventricle, made sure that it is not interactive with the mitral valve apparatus, and that it is well above 3.5 centimeters into the left ventricle, such that the ejection port is in the left in the aorta itself, so that there is no recycling of this blood. Otherwise, if that is also in your left ventricle, it's only recycling all your blood here. So we have to be very careful that we confirm proper placement of the Impella. And the Impella works on the Archimedes screw principle, which basically is shown right here. And this is how it sucks in blood from the inlet and deposits it to the outlet. Here is an echocardiographic evidence of the Impella sitting in the left ventricle, and you can see this artifact that is sitting right there. That's your cannula in passing through the aortic valve into the left ventricle. We also have the Impella Smart Assist, which is the Impella, which is 5.5, and that delivers peak flows greater than 6 liters per minute, but it's not available just yet in all centers. And it is got, it's interesting because it integrates the information data and the informatics to include the left ventricular end diastolic pressure, as well as the cardiac output power to support weaning algorithms from these assist devices. So it's a super smart device. And repositioning of the Impella is often performed at the bedside under ultrasound guidance. So what are the contraindications of an Impella? Well, we looked at that and we know that the mural thrombus in the left ventricle is a big contraindication, otherwise it'll suck the thrombus into it. Or the presence of a mechanical aortic valve or any aortic stenosis or calcification. Moderate or severe aortic insufficiency, which will cause recycling of the blood from the aorta back into the left ventricle, is a contraindication. Severe arterial disease in the femoral arteries or the axillary arteries, which will preclude placement of this Impella system, is yet another contraindication. And the presence of atrial or ventricular septal defects, including post-infarct ventricular septal defect, you do not want to place an Impella in those patients. Significant right heart failure is a contraindication, as is left ventricular rupture and cardiac tamponade. The other devices other than balloon pump and the Impella, which we talked about, is the tandem heart and the VA ECMO. The tandem heart is a percutaneous extracorporeal device which will give you flows up to 4 liters. And this is how it is placed. Now remember, this is the only device that is placed in the femoral vein. We talked about all those being placed in the femoral artery. Well, even the ECMO is placed in the femoral vein, but of the devices that we mentioned, we have blood, we have the device going through the femoral vein into the IVC, into the right atrium, through the interatrial septum into the left atria. And from here, it suctions blood, takes it out through another channel, and goes through an oxygenator, and then goes into the femoral artery. And that is how it provides support, taking flow from the left atrial side into the femoral artery or the aorta. And it reduces the LV preload, wall stress, and oxygen demand. But there's always a technical challenge because of the transseptal puncture requirement, and that is a limitation to its widespread use. Tandem heart can also cause limb ischemia, 3.5 to 11%, major bleeding, gastrointestinal bleeding, cerebrovascular accidents. All of these can cause a stroke. Hemolysis has been reported, and a risk of atrial perforation when you push in the catheter from the septum itself, that can go all the way and perforate the wall of the left atrium. So that is, again, another complication. What about right ventricular mechanical support devices? Well, right ventricular failure is a major cause of morbidity and mortality. And right ventricular support devices have a major role to stabilize patients with cardiogenic shock. And they can be bridge to therapy or bridge to recovery. The right ventricular devices are the Impella RP, which is placed again through the femoral into the IVC, and again right from the right ventricle into the pulmonary artery. It can suck blood from the right atrium and eject it into the pulmonary artery. You do not need any oxygenators for these patients, because it is basically sending blood to the pulmonary artery, which is going to obviously send it to the into the lungs. And then, of course, you have the ECMO as well to support the right ventricle. The Impella, you have a better diagram up here that can show you the RP Impella. And it treats the right ventricular failure, as we said, and all the right ventricular failure whenever left ventricular assist devices are placed. One of the important complications you've got to worry about is right ventricular failure. So you have given them a nice pump, but then the right ventricle fails. What about the myocardial infarction patients or heart transplant patients? They all can also require right ventricular support, and that's when you would use them. Let's look at the prospective Recover Right study of the Impella. This was looking at the right ventricular recovery. And they actually found that they did a study looking at populations, which they divided into two cohorts: 18 patients with right ventricular failure following LVADs, or 12 patients with RV failure after a cardiotomy or myocardial infarction. And they found that with the right ventricular assist devices, the overall survival at 30 days was 73.3%. Now, I need to mention that patients in cardiogenic shock from left ventricular dysfunction, the mortality in those patients is 39 to 55%. And by using a cardiogenic shock team, that mortality has been reduced considerably, and the survival has also improved to 72%. So any survival that you can improve to 72% is indicative of the benefits of these devices. You have to keep these patients pretty sedated and immobile while you have them in place, because you don't want a device migration. What are the adverse effects of some of these short-term mechanical devices? Now we know what the indications are, but what are the contraindications or adverse events? Well, bleeding, thrombocytopenia, hemolysis, vascular injury, renal dysfunction is very common, aortic valve injury, cerebral vascular accidents or strokes, limb ischemia, device migration, or myocardial infarction. And this chart here compares these various devices and talks about the cardiac output that you can get through them, the kind of cannula that you need for them to be placed through. And you notice that for the tandem heart, you need a larger cannula. For the Impella 5, you need a larger cannula. So obviously these require cut downs. And the ECMO, sometimes you could use a larger cannula as well. And it talks about all the complications, the hemolysis, etc. What are the contraindications for insertion of these devices? We talked about the aortic valve. Metallic aortic valve is a contraindication, aortic regurgitation, aortic aneurysm, severe aortic or peripheral arterial disease, left ventricular or left atrial thrombi, bleeding, diathesis, thrombocytopenia, or any contraindication to anticoagulation. Any patients with irreversible neurological damage is not a candidate, as is a patient with uncontrolled sepsis. What is the future of these devices? Well, you can have more and more miniaturized devices available, and that is what we're looking at, so that we allow these patients to ambulate and go home. The implantation time, we're looking at the possibility of the time being longer than 1 to 2 months. Less anticoagulation may be used, and we're looking at smaller cannula sizes and pulsatility of flow. So the take home from this lecture is that temporary mechanical circulatory support devices are being used with increasing frequency. Hospitals with the cardiogenic shock teams have demonstrated an improvement in survival to 72% because they have an algorithm of which device for which patient and when do you actually intervene and how soon do you intervene. Selection of a device is guided by the level of the hemodynamic support that is required, the institutional experience with the device, and the device-specific risks. Patient selection is always made using a multidisciplinary team approach. Some of our post-lecture questions. Which of the following statement is true? Mechanical aortic valve is a contraindication to Impella 5 use. Tandem heart requires venous cannulation. Vascular injury can be a complication of temporary mechanical circulatory support devices. All the above are true. That is the one. What's the next question? Well, which of the following statement is true? Roller pumps cause minimal hemolysis. Balloon pump is helpful to decrease mortality in patients with acute myocardial infarction with shock. Impella 5 can provide up to 5 liters of flow. All the above are true. Well, we know the roller pumps cause a lot of hemolysis. We know that the balloon pump did not decrease mortality in patients with AMI. And the Impella 5 can indeed provide 5 liters of flow. So that is the right answer. And that is the end of this particular lecture. And I thank you.